Welcome to the first episode of the Harvard Extension School Psychology Student Club podcast for the 2025 to 2026 academic year. We have with us Dr. Belinda Bellet, who is the founder of Brooklyn Heights Behavioral Associates, which is a DBT-focused therapy practice using evidence-based treatments to help patients who are struggling with suicide, trauma, and co-occurring conditions. We are so honored to have Dr. Bellet with us today. Dr. Bellet has developed her skills working at the Bellevue Emergency Department, working with severe mental illness. Dr. Bellet also has extensive experience working with FEMA to support 9/11 first responders. So thank you for joining us.
Absolutely.
So the first question that I want to ask you is, I'd like you to describe the work that you currently do with Brooklyn Heights Behavioral Associates.
hmm
Um, Also, what inspired you to start this practice?
Oh, absolutely. Well, in the practice, I specialize in complex multi-diagnostic problems for people of all ages. So these are patients who come in with, sometimes many diagnoses. Um, the symptoms have been long lasting. Maybe they started in childhood. There's a lot of factors that go into the reasons they're struggling. And I work with people of all ages, and I deliver evidence based treatment.
Okay.
And I have a team, so it's a group practice.
Um, what inspired you to start this practice?
Well, I, well, so before was in my private practice, I worked in a hospital. I worked at Bellevue Hospital for many years. Um, what inspired me to get into um, this profession what goes way back, probably to my childhood, where and my specialty, what I really am passionate about, is um, interrupting pathological interrupting pathological, I hate to use that word, but processes within family systems. So my orientation is in attachment and evolutionary psychology. And what I've seen through my work is that people who have secure attachment are are more in an overall sense of well-being, and then people who have insecure attachment, and that attachment relationship is essential to whether this is going to be cultivated or that it's going to be cultivated, and you can make those changes at any age within any relationship. So that's what's wonderful about this work is, through behavioral change, you can manifest many pathways to health. And so just growing up in my family, seeing all the, things that I was observing that weren't going so well, I was pretty fixated on trying to figure it out. And when I was in college, I thought about going to medical school. I'm not suited or cut out for it. So I had a little bit of a crisis, and I actually took a year off from college to figure out what I wanted to do. And then I went back because I thought I might do psychiatry. And then I went back and realized, no, I want to talk to people. I want to be a therapist. I want to really help people figure out, how to live better lives with developing insight and behavioral change. It was more true to who I am. So then I prepared for grad school, and I also worked in a suicide hotline in college. So that was my first introduction to working with suicide. I worked, it was actually not, it was over the telephone, but it was such a local community and local service. It was in my college town, and it was a phone number that we'd post, all over the place. And there were a bunch of us that got trained, and it was a very intimate group, and we were doing, really important work. And so that's how I got started with it.
That's
But
amazing.
over 30 years ago, yeah.
And What did your path look like kind of since then?
So since then, I moved to I've been in New York since '93, and I took a few years off just to be an adult and play around the city as a paralegal pre psychology, and then I went back to grad school, um, and I did my graduate training, and it was then I got an psychology internship at Bellevue Hospital, which is a premier public flagship hospital in New York City. Yeah, where I always dreamed of working, which was kind of crazy.
Well, congratulations.
Yeah, thank you.
So while working with suicidal patients, how do you manage the stress of dealing with that population?
Hmm. I think that the team environment, the peer support, really spoke to me, and my specialty, dialectical behavioral therapy, has built-in support and team. You have to be on a team in order to treat suicidal patients, and that is, I just that's how I get through this. I have support of my team. Um, I'll often get supervisors for myself. I also have a network of professionals beyond my team who I meet with regularly to just talk about work in general. Um, and anytime I'm really struggling, I have my go-to people, to um, connect with. And a lot of the buoyancy that I have all these years later really are, because I'm also using DBT skills to manage the stress. And I've been a mindfulness practitioner since um, that first moment where I did mindfulness, and I was like, felt transported, and I was like, what is this? I want to know more about it. And I incorporated it into my dissertation, so I wound up doing a lot of research on it, and how it was just starting to get incorporated into like medical treatments. Part of my dissertation, um, came across. I was very interested in mindfulness, and then I started researching it. There were programs around that had been embedded in medical institutions. I don't know if you've ever heard of mindfulness-based stress reduction, MBSR, but it's through Dr. John Kabat-Zinn, and he developed this at Harvard many years ago, and it became a program, and I got trained in it very early on before DBT. And I've
Okay.
been doing DBT since 2000, so I've done mindfulness for a long time.
So, for our listeners who aren't familiar, could you describe DBT and also how your practice uses it in a unique way?
Sure. Dialectical behavior therapy was developed in the 80s through many research protocols by Dr. Marsha Lanahan from the University of Washington. And the textbook came out, it was published in '93, and was, there was a companion skills manual. It was very small, not the way we know it today, which is very big and complicated. Um, but that became something that was very sought after. She started on the West Coast, so you started to see more programs popping up on the West Coast, trained by her and her team, and then slowly it crept over into the East Coast and other cities. Some of her graduate students would leave and go here and there, and then they would start training. And then she developed a training program. So when I started learning it in 2000, actually there was a team at Bellevue who were getting intensively trained through one of her trainers. And it's very intensive to learn it. It takes a lot of time and a lot of money. Um, One of the things that she would always talk about, which was the dialectic means multiple truths exist in the world, many of which are incompatible and irreconcilable. And one of the irreconcilable things about DBT is that it's so expensive to train, and so it's going to be expensive to deliver. Otherwise, the person who got trained can't. It's not a great business model, and at the same time, people who really need it can't afford it. So that's the dialectic of DBT. But I've found ways around that, offering training through my practice where I have interns and externs and can do it at low cost. And I also have a model through my practice of doing each therapist works with a percentage of low fee patients and sometimes pro bono. So that's how I reconcile it. But anyway, it's a treatment that is very comprehensive. The basis of it is, the heart of it is behaviorism. Dr. Linehan was a behavioral scientist, and so she set out to figure out how to treat suicidal patients, which was an untreatable patient population at that time. And patients who just wouldn't respond to medication, didn't respond to traditional therapy, psychotherapy, which was more psychoanalysis at that time. And so she's like, well, I'm a behaviorist. And she also struggled with this. She was institutionalized for many years, had, in one of those terrible institutions back in the day where she had, she wrote a memoir. So if anybody's interested in her history, she's got a memoir out called Building a Life Worth Living, and I would recommend anyone read it. But her institutionalization was really severe. But so that was really what motivated her to figure this out. It's like, I'm a behaviorist. I know I can figure this out. So she really spent a lot of time studying it and putting these problems to behavioral change, and writing everything down, and finding subjects, and it's great. It's got multiple modules. It tackles multiple realms of functioning. So it's at the heart of DBT is it helps with emotion dysregulation. So, and it targets people who have intense emotions. So people who have intense emotions, some people naturally grow up and they can manage it. They've got resilience. They've got some biological strengths that, through the roll of the dice, they're just able to handle things. Some people with the roll of the dice have biological vulnerabilities. So it makes having big emotions really hard. And DBT provides scaffolding through skills to help manage those emotional peaks so that the person can cope better. And if you can cope better with your emotions, you can reach your goals, right? You can pursue your dreams. You can have more energy. You can have more confidence. You can have better relationships. So it's really at the heart of DBT.
Thank you. So I know dialectical behavior therapy was originally developed for borderline personality disorder. And I know that this disorder has been stigmatized pretty seriously by practitioners.
Very much so.
As somebody who is running a DBT practice, could you speak a little bit about the stigmatization of the disorder and also what you've done to combat it and how you see these patients presenting?
Yes, absolutely. So Marcia is always telling a story every time she had a chance to. The reason she picked borderline personality disorder is because when she applied for her grant, to get these studies off the ground and have legitimacy through the National Institute of Mental Health, she had to put it as a DSM diagnosis on what it was that she was studying. She wasn't studying borderline personality disorder. She was studying people who have chronic suicidal ideation and self-harming, who were considered, they just weren't responding to medication or psychotherapy. But she had to do that, and she worked tirelessly to help destigmatize this group of people. And even today, it's I think there's something with the way it's like borderline. It's like the word itself is so like, ooh, what is that? It's like scary and intriguing, and um, I think it's got its own kind of feeling to it that just creates a little stress and fear, um, which is, it just shouldn't be. Um, Sometimes the diagnosis helps people, in my experience, and sometimes it's not that useful. But what really isn't useful is getting attached to a diagnosis, because we're so complex. We're so complex. Her original work, the original studies were for trauma, to treat trauma. And these are people who've been traumatized in an early environment. So these are people who have traumatic attachment disorders. And that could be anyone. You could have PTSD, you could have depression, you could have, but it when you grow up in an environment where there's traumatic relationship patterns, your nervous system goes absolutely bonkers. So it manifests in so many different ways. The reason DBT is so comprehensive is because it's trying to capture as many problems as possible. And people who have traumatic relationship attachment disorders have a lot of symptoms. So that's why she, made it as comprehensive as possible. But the way I try to bring down the stigma is, I educate a lot about, I just try to, advocacy awareness. I try to educate my local community as much as I can. I have put out newsletters, and it's really about increasing empathy and understanding. And, I remember when I was first training at Bellevue, and I was working in the psychiatric emergency room with all these, there's a multidisciplinary team of nurses and psychiatrists and attendings and residents and medical students and psychology externs and interns and psychology staff, and of course, patients with borderline personality would come in having made a suicide attempt, and there was so much belittling and shaming of them. And I remember and I wasn't a DBT practitioner, but I was pissed. I was like, what the hell is going on here? What is going on? And I would defend them, because my orientation was attachment and evolutionary psychology. So I'm always thinking through the lens of, well, what is this person's childhood like? What were their circumstances? What were the psychosocial stressors? What was their life? What were the environmental stressors? What were we're looking at a human being who's suffering. Let's, come together and help. And so I just, I was so kind of outraged. And I was very vocal, as I am. But, and now I do what I do. So it's important to be a champion for people who are suffering.
Thank you for doing that. Yeah, I very much appreciate it. So, how do you see this stigmatization impact the patients who are labeled with this disorder?
It's very frightening to feel like you have a disorder. Not a lot of people know about DBT either. So people who have this, I don't know where they get their information, but I imagine TikTok and all those things probably foment a lot of fear and misinformation. Or maybe, you know, the term gets thrown around a lot in social groups or whatever as derogatory. And people come in and they don't know, or they don't know about DBT. So you're like, oh, I have borderline personality disorder. There's no hope. A lot of people come in to DBT and they've never heard about it before, which I'm so surprised by. So I think there's a there's a I think there's an advertisement problem. We're not getting visible enough. Like schools too, like families suffer for years with kids who can be easily treated with well, it's not easy, but like within months to a year, their kid could be well on their way of, significant improvement. And they go years and nobody's ever said to them, their doctors, their physicians, they've had psychiatrists, they've had school counselors. These are my local communities, and I've never heard of DBT, and I'm going, how is that possible? So I think a lot of it is just like my child has these symptoms, or my daughter has these symptoms, my adult child has these symptoms. There's no hope. There's no treatment. And psychiatry doesn't do enough. The medication management is not how people get better. Many people take that path and wind up with a host of other problems, like terrible side effects, and yeah.
So, on the flip side, when you are able to destigmatize these symptoms and people who are labeled with this disorder, what are the effects you see with
Um,
proper treatment?
right. So the other half of DBT, so it's behavioral change, but the other half of DBT is acceptance. And those are the dialectical tensions, acceptance and change. But in order to change, you have to fully accept without judgment what your problem is. And if you if you're not able to accept your problem, you're going to panic about it, and it creates more suffering. So it's very, very important to to embrace the problem and orient towards it of with hope. I can do something about this. I've got tools and it changes the um just it changes the whole ball game, right? It's like now it's a completely different way of thinking, orientation, the way that, it impacts your mood. Like I just had a bit of a medical trauma. I'm okay, but I knew what the symptoms were going to be afterwards because I know what trauma feels like. I know what the diagnosis. I know like the criteria. Checked it. I was like, okay, that's that symptom. That's that symptom. That's that symptom. I know it's totally normal, and it helped my fear. Had I not understood to expect it and that it would be normal, and that it's just it's the brain and it's the body and it's how we process it. It's our psychology and it's the way everything kind of has to, just go. We have to go through it. But I was able to understand it and see what was happening to me without judgment, and that allowed me to get through it easier with more peace. And it's the same thing with anything.
So what does it feel like to, sorry, I have a cough. Um, what does it feel like when you are presented with a patient who comes in with suicidality and, various diagnoses, and to see that patient really go from having a life they don't want to be a part of to seeing them begin to flourish and to build a life that they think is worth living?
That's tremendous for me. That's the reason I do it. And it happens so quickly. And my team and I are always like, it's just, we sit back and wonder. We're like, wow, just this is incredible. It's like taking someone who's completely starved, malnourished, malnutritioned, no sunlight, no food, no warmth, no connection, to suddenly and within a matter of months, they're, they're, you said flourishing, and I think absolutely, they're just finally able to emerge as the human um, being they were intended to be on this planet, and it's just the most beautiful thing.
Do you find that that patients who once, um, took these diagnoses and these very stigmatized diagnoses to heart are able to accept and overcome that and use it as a source of resilience?
It absolutely can be a source of resilience, overcoming anything, right? I've just, personally looking back at my own triumphs and, life's hurdles, and, getting through to the other side, it does promote a lot of pride and inner strength, and, to reflect back, wow, I really, I've come a long way, and my life is so different now, and I'm so proud of myself. It just engenders a ton of confidence, and yeah, I think absolutely.
Um, how did you begin to build your team when you started the practice?
So I actually went around. There weren't that many DBT practitioners, so I did an internet search, and I looked also at hospital centers, because I knew that sometimes, outpatient clinics and things at hospitals might have some people here and there. So I asked around, looked around, and I wound up finding. I remember calling this woman out of the blue. She was I think she was in social work school, working at Mount Sinai outpatient clinic on the upper, I think it was the Upper West Side, and I was like, let's have coffee. And I remember the coffee. We were sitting, and I was like, I'm starting a DBT team, and do you want to come and run group for a couple hours a week with me? I have an office in downtown Brooklyn, and you can just come, and then we can have a team. It was just the two of us. I was like, we can have a team, and we can talk. And that's how my team started. It was Tuesday in the afternoon during lunch, and I still have that team running to this day. But yes, so we would co-lead group together. She was on my team for consultation. I saw the patients. She didn't see patients. She was still at her full-time job. But yeah, it was fun, and then just grew from there.
How have you seen, I guess, your educational efforts and your, sorry, I don't have good wording for this. Um,
Some water.
yeah. Um, so, how have you seen your advocacy and educational efforts impact kind of larger programs outside of your practice? And have you seen this type of practice um, and this type of treatment begin to spread?
The treatment has definitely begun to spread. There are more and more practices out there doing DBT. Being trained through behavioral tech is essential. There are lots of people who are not trained through behavioral tech. Behavioral technology, behavioraltech.org is Marsha Linehan's training institute. And a lot of different places give DBT training certificates where the therapist comes in and there are many modes of treatment. One is the skills class, DBT skills class, where you learn, as a therapist, you learn how to teach the skills. The skills get taught in a like 6 to 8 month weekly sessions with other people who are engaged in individual DBT, comprehensive DBT, and it's didactic. It's not therapy, but it is a therapeutic intervention. But it's to learn all of the skills. And individual therapy is where you do your targeted, what are the behavioral targets, the specifics around what you're suffering with, how much you're suffering, and developing a hierarchy. It's very collaborative. It's also, there are totally different skills for the therapist to do individual therapy. That's part of the training, is we learn skills as a therapist to disseminate individual therapy. Plus we provide phone coaching. So all of this goes on in the team consultation. And then skills is a quarter of the treatment. But a lot of therapists will get trained in DBT skills and think that's, now I'm a DBT therapist. Or they'll advertise that they're doing DBT. And so this is a problem, because if you're a suicidal patient, it's important to know that if you want to get better, you have to see someone who's doing comprehensive DBT trained through the Linehan Institute. No one else does that training. They offer scholarships. The DBT Linehan Institute, the behavioral tech offers scholarships. So they're making it more affordable. And so it is doable to find. And more and more people are trained in it, but you have to be an informed consumer. And I always tell people, like, you're the wisest person in the room. If you don't feel it's helping, and I'm talking about a short period of time, like 3 to 4 sessions, you've got to find somebody else. Like, this therapy is going to be very solution focused, collaborative, clear on how the therapist is going to proceed. They have to show a lot of expertise in the room and be very methodical with getting you through those first few months. The first few months can feel really frightening for everybody if you're suicidal, right? And you're just a new patient too. So you got to know that you're working with someone who has an expertise, the correct expertise. And you will get better. But if you're not working with someone with the correct training, you may or may not get better.
That makes sense.
That's the danger. Yeah. But more and more people are getting trained in it.
Okay. So many of our listeners are psychology students. Could you kind of describe what goes into that training in more detail?
Sure.
And how to pursue it?
Absolutely. Well, if you want to just get a taste of what DBT is like, you can do something like an initial training and skills. I think it's great because then you learn the skills yourself. You practice, what are the skills? They will improve your life no matter, what you're struggling with, or, even just, let's say you don't struggle much. Those skills can enhance your life. And I think they're skills for anyone. They're skills for life once you learn them, and they'll just, give you a better life. So I think that's absolutely fine and a great way to start. You could also take a skills class. There are many practices and places now where you could take a skills class as a patient. I know a lot of people who've just done that. Um, and um, I mean, I've done that quite a bit in my career. If I want to learn something, I'll engage in it as a patient. I was curious about hypnosis. So I went to see a hypnosis practitioner and I got it done on myself. So that's a great way to learn. Um, and then behavioraltech.org has the official training sites. And now I believe they have a fully remote option, but it is expensive, but it's also, they do offer scholarships.
Okay.
So they have uh, it's months of, you have to learn, you have to read all the textbooks. It's like a graduate training program. You have to read all the textbooks. You have to get a team. If you want to do comprehensive DBT, you have to have a team. You have to have consultation. You have to run groups, and um, you have to see suicidal patients. And then that training, you have to present cases. You have to show and demonstrate capability. And at the end, there's like a big presentation of your case. So it's like 9 months.
Okay.
So
Is
it
that
is.
a training you get after a master's degree or a
Some
doctorate?
master's programs have them built in. That's another problem, though, is that a lot of graduate programs don't invest the money to have trainers come in. So, I was very fortunate to be part of a family that I had two parent income. So with my spouse, both of us have, that we're both working, and so I was able to afford it. If I were single and a private practitioner without another income to help support these professional dreams, I would have figured it out, but I'd probably be in a lot of debt, and but so there are ways to do it if you really want to do it. Um, and also this, now they have scholarships,
Okay.
but
Thank
it is an investment, but it pays off in many ways.
Yeah, it sounds like it.
There's another evidence-based treatment out there called CAMS Care, and it's the CAMS framework. It's the collaborative assessment and management of suicidality. It's an evidence-based approach to treating people suffering from serious thoughts of self-harm. I'm just reading off their website. They're It's easy to learn. It's less expensive, and it's very important. I just did a training on suicide informed care. I think every therapist out there needs to be a suicide informed practitioner. You will have a suicidal patient. Even if you're not, you say, I don't want to treat suicide. You will have a suicidal patient. Suicide is on the rise, and a staggering proportion of the population will experience it. So you need to be prepared, and you need to know what the assessment tools are. You need to know what to do. It's not enough to say, I'll figure out what to do when it happens. That is not ethical. You've got to be prepared. So CAMS is a great, I think CAMS, if I were, that's what I would do. If I couldn't afford DBT and I was a single practitioner, I would get trained in CAMS and have a protocol. The other thing that I think people should do is if you're practicing on your own, create a group of other practitioners where it's and mimic a DBT consultation team. So you're there for each other in a crisis. You've also planned, like you're doing housekeeping. You're planning procedures, business procedures. What do you do when? When do you hospitalize? When do you call the emergency service? What do you do before that? And CAMS provides crisis intervention, um, so you and the patient develop what to do in a crisis, but you'll already know how to do that when when you find a patient is in crisis if you're trained. So a lot of therapists are not prepared and they'll just call 911 or they'll call the parents and say, you got to take the child to the emergency room. And this causes so much trauma to someone who's already experiencing a lot of pain. And it's an uninformed intervention. So get informed.
Okay. Thank you. Um, so, aside from being a practitioner, for anyone who is struggling with suicidality or has a friend who is struggling with suicidality and maybe doesn't have the resources to get comprehensive DBT, what would you recommend?
Right. I would say that most private practices probably offer some sliding scale or um, options. So I don't hesitate to reach out to some local private practices that do comprehensive DBT, even though they're private pay. See if they can, make exceptions. Insurance companies, if you have in-network benefits, these programs don't, are often not in network. It's a big problem. Um, but asking um, asking make sure that you go to a therapist who has some kind of training in risk assessment and intervention. And the CAMS actually has on their website a lot of all of the people who they trained. And so if you can't afford DBT, I would go to that website, and you need it if you need it. Go to that website and see if you can find someone who's trained in CAMS.
Okay.
And that's, like I said, it's not as expensive, so the fees probably for those therapists are not as high, to justify the cost of the treatment. Um, yeah.
So September was Suicide Prevention Awareness Month, and I know we're a little bit late, but do you have any kind of words of wisdom to promote awareness about this cause?
Yeah. So, I mean, suicide's on the rise in every demographic, particularly marginalized groups right now. We have to be really, really aware of what's going on over the last couple of years targeting marginalized groups in this country. There's a tremendous amount of fear rising and feelings of alienation and being othered. And alienation is a risk factor for suicide. Feeling alienated, feeling isolated, feeling alone um, is a risk factor for suicide. And so we have to be embracing our communities. We have to show that we're allies as much as we possibly can. You know, just if you have that feeling of advocacy, then go out and be, as vocal as you can be. See it, what other people, friends or people who are not friends, just the larger community, try to get involved in some way. Do a lot of these organizations have lost funding, and so you could volunteer. Um, the suicide hotlines, the Trevor. I don't know if you. There's many places where you could volunteer.
Okay. Thank you.
Absolutely, it's been great. I've really enjoyed it.
Yeah, thank you so much for joining us. And this is all really, really important,
Yes.
really important information. It's so great to have your insights about these topics and these populations. Can I ask you one more question? So, you mentioned mindfulness being part of your dissertation. So, could you
Mm-hmm.
just speak about mindfulness and how everyone can use that kind of on a day-to-day basis?
Mm-hmm.
Students, practitioners, patients.
Sure.
um, and kind of the magic that it brings.
Absolutely. It is so essential for my well-being. I use it every time I need it. So this is self-intervention. It's like a tool in your tool belt. I was I was doing a series of talks over the last couple of weeks in person, and it was a large auditorium, and I haven't done that in a while. A lot of my talks have been, you know, on the internet, and so I noticed myself getting anxious, which again, non-judgmentally, it's like, yeah, that makes sense given, what I'm doing, and I'm gonna use mindfulness right now to help my nervous system calm down. And I have these go-to ways of meditating or being mindful that I've honed over the years that just like connect me with that deep feeling of what you really want to feel is a sense of intense concentration. So whatever it is that you're good at concentrating on, go there. So for me, it's hearing, and I've always been drawn to like classical music, and when I'm in a state of anxiety or fear, and I know I need to calm my nervous system down, I'll pop on my headphones and I'll put on some symphony or orchestra, and then I'll follow an instrument. I'll pick an instrument at the beginning. I'll say, okay, in this song, I'm just going to listen to the flute. But you have to really pay attention because, throughout the course of the song, it's going to come and go and change and go up and down. Or I'm really going to listen to the cello. Or I'm really going to listen to the violin. Or I'm just going to focus on just one instrument. Right? And that's developing that skill set. It's really harnessing the powers of your concentration. That if you're when you're doing it, you're promoting all of these brain waves that are so powerfully healing, but you're also not attending to the thing that's making you anxious. So it's just grounding you. It's taking you out of the thing that is going to drive up your emotions in a negative way and throw you off, and keeping you steady, regulating your nervous system, getting those positive brain waves going, and improving your ability to concentrate at the same time. It's like the best skill on the planet.
Okay. That's pretty much all I have for now.
Okay.
Thank you so much for
Absolutely.
yeah, thank you for joining our podcast. We really appreciate your
Absolutely. Anytime. Been such a pleasure to connect with you, and I just imagine your greater community, and I'm sending, lots of hope and good energy, and I hope everybody can manifest, your dreams, and be illuminate in the ways that you were meant to be, on this earth.
We really appreciate all of the insights you had to offer. And thank you so much for your time.
All the best.
Yeah, thank you.
Okay.
Okay. Have a good day.
You too.
We hope you enjoyed the first episode of the Harvard Extension School Psychology Student Club podcast of the 2025 to the 2026 academic year. We look forward to having you join us again, as we'll have many more exciting guests to join.